I'm Margaret Flinter, Vice President and Clinical Director of one of the country's oldest and largest community health centers. Our health center provides a broad range of services, medicine, dentistry, and mental health care to over 50,000 patients a year from our offices in central and southeastern Connecticut. But we can't do it all, and we can't do it alone. Right up there with the lessons of our local experience has been the learning from the remarkable programs that are being pioneered in communities around this country. The story we have to tell is about collaboration, both local and national. And though it could be told in many ways, ours begins in an herb garden in the north end of Middletown, USA. And it will take us all over this land.
Oh, my land. Oh, my land. Oh, my land. Oh, some better thing. Oh, my land. Oh, my land. Oh, my land. Oh, some better miles in my land. Oh, my land. My land. Oh, my land. My land.
Choice created a Sustainable Healthcare Access Council. And what I found was that even though while people were cynical in their words, they started to come to the meetings, and there was a tremendous sense of power that started to be created by people just being able to talk about a hopeful future.
You gotta let them argue. It's an uncomfortable thing. When people argue, you tend to not want that to happen, especially in small communities, because everybody knows each other. But the more they fight and bicker, there's a point where they get tired of that. They sit back and they say, all right, now what can we do?
Everybody was sort of scared of what somebody else was going to do to them. And so sometimes in the early meetings, what motivated people to attend in the conversation was they just wanted to make sure that nothing was going to be taken away from them. And so it was a process of getting them to move out of that sort of defensive posture that comes from, years of dwindling resources and competition.
The county as a whole, everybody exceeds the norms in Michigan for end-stage renal disease, for diabetes, for ischemic heart disease. I mean, you name it, we've got it. We're a very unhealthy community. And then if you look at the African American community, it even exceeds our county norms. So really, really bad stuff. And what we did was we put together several breakfast meetings. We identified leadership in the Black community to come together, sit down, and so we'd get up in front and we'd say, well, this is really bad, and this is really bad, and this is really bad. Well, after doing a series of these meetings, people were just plain pissed, for lack of a better term. They were angry. It's like, what do we do? We need to do something. John said, well, it's time to put them at the table, get them going. And he said, let's get Irie. Irie just retired. So
what we were able to put together with our vision was to get everybody to buy into the purpose, which was 100% access to a defined set of services that everybody should have a right to regardless of their ability to pay, that we would achieve over 5 to 7 years. So the notion was nobody would be uninsured in our region.
When the coalition first started, it was due to a crisis. Community clinics were about to close. There was no county hospital. And when the parties came together, particularly the hospitals, county, and Kaiser Permanente, and decided collectively to take action together, it benefited all of us. We ended up preparing a plan for a county organized health system. We got funding from the state to become a pilot in Solano County. That gave birth to a very successful partnership health plan.
Incredible results within the first year. Emergency room usage dropped by 50%. Inpatient days decreased, birth outcomes increased. It was like an event, an occasion, a success that just glued this group of folks together.
When I hear people discussing the healthcare system, it almost always means that there's a problem. There's a problem for the patients to access health care, problems for state workers who become overwhelmed with the paperwork and the greater need, a problem for the providers who have stretched themselves to the limit.
All I know is I've got a world of folks out here who need good access to quality health care, and they're not getting it. So my job then becomes to figure out why can't they get it, and when I figure that out, to remove that barrier.
Then the coal company came with the world's largest shovel, and they tortured the timber and stripped all the land. Well, they dug for their coal till the land was forsaken. Then they wrote it all down as the progress of man. And Daddy, won't you take me back?
Looks like coal.
This is called Coal Harbor. It's the name of this mountain.
A lot of disease that's associated.
With the coal mines, yeah, emphysema, black lung. I've been doing this type of work for around 8 years. I like it. I like the people. When you go to the doctor on the 16th, speak to them about an annual exam. Has any doctor in the clinic done that to you?
I don't think so.
Don't think so.
I really see these lay health workers as being the future of health care. There's not enough nurses there, and it's not the total answer. It has to be that there's continuity, not just in the doctor's offices and the hospitals, but once the patient leaves those, that someone helps navigate them through the healthcare system. So we're actually able to take those numbers and give us an idea of the impact of this program, if it's actually making a difference, if it's actually reducing ER and hospitalizations, and it has.
When we did an analysis of this, trying to figure out what was the best way of improving this system, we discovered that 6 million, half, went for care for 129 people. And when we researched that a little bit more, and as a matter of fact, we went back and looked at the charts for all 129 of those folks and found conditions that were highly preventable. So it said clearly we needed to do something to create a better system in preventive care for that population.
With this calendar, we were able to get the attention of the African American community as a work that was sincere and really about the business of helping the community to make some changes. And on this calendar, we feature men and women that are survivors of breast cancer, and believe it or not, we actually got men to model on this calendar that are survivors of prostate cancer.
In the first year of MCAP, we researched establishing a 340B pharmacy program. We could have gone the usual route of setting up pharmacies within the community health center, but running pharmacies is not one of our core skills. Instead, we contracted with a local pharmacy. The arrangement has worked out well, with minimal startup and inventory costs.
The ability for patients to easily get to their drugs and to a pharmacist in their community, I think, outweighs all other factors. So next steps for CHC. I'm very proud and happy to tell you that in New Britain, where you could literally throw a softball from our parking lot to the new Walgreens store, we have become the first community health center in the country to get Walgreens to sign with it for a FQHC 340B contract. They have 4,000 stores across the country. Having worked it out with us, I see absolutely no reason why they won't be open to doing this with anybody else.
We are located in a very large health department here in Asheville. What makes us unique is we have a primary care clinic in the facility. We fill prescriptions for this clinic, an average of 550 a day. About 15 to 20% of that volume is free medication from pharmaceutical companies. Medication is very expensive, so it really doesn't take a huge amount of medication to reach a magnitude of a couple of $1 million, which is where we are right now. In the last 3 years, what we spend is going down and what we're getting free is going up.
That's good.
Yes, it's a good thing for county budgets.
My name's Late Night Dwight. I own a couple of restaurants in Muskegon, Michigan. Like most restaurateurs, we didn't believe that there was a program out there that we could afford to have all our employees be involved in it because insurance is just getting so high. This particular program makes it so that even our waitresses, dishwashers, and everybody can afford some health insurance. And in this day and age, to be without health insurance is like to be without a car. Everybody kicks in. everybody wins. And that's what we like to see in the good old USA.
When I opened the Glamazon, the premiums were just so outrageous that I knew it wouldn't be something that we could offer. And so I was kind of in a dilemma at that point as to, what are we going to do? How am I going to draw employees? What's going to keep people from leaving?
People said, yeah, I could probably do something, but it has to be under $50 a month. So we knew we had a business willing to contribute $50 per employee or something under 50. And we had individuals willing to participate with something under 50 that could be used to help pay for benefit.
Oh, there's a big old sign, big old billboard, bottom line, $49, house coverage.
Our state was leaving money on the federal table, so to speak, and the state said, we'll let you pull it down. And that match money then becomes the community share of the 3 share. So $150, we wrote our own contracts with our own providers. We set up a 501c3 to administer the program, and we created our own health program. No HMOs, no, government-run thing, something with community oversight, and 97% of our doctors participate, and both of our hospitals participate, and hospice participates, and behavioral health providers participate, and people are mainstreamed, and they've got a pharmacy benefit, and our co-pays are low, $5 to see a primary care physician. We had over 400 businesses that participate. Just about 60% of them never offered a thing ever.
Just that easy, and then it was just up to the employees and myself to decide, do you want the coverage or not? And like I said, you'd have to be a fool not to, because it's so inexpensive. So it's a great program. It's for a lot of different reasons, I think. For people that don't have insurance and for, small business. Perfect. Perfecto.
I have to give your mom all your papers and things. Access to medical specialists has long been a great barrier for uninsured patients. Our solution in Middlesex County was to work with MPS, an association which includes 90% of the county's physicians. Together, we invited the private practices to adopt a sliding fee scale, similar to those used by our health center and the hospital.
We are a medical practice, and we do not have the expertise nor the time to make these decisions, and that was always something that we found very difficult, because it's important that we're fair and the right determination is made.
In the past year, more than 50 physicians representing the major specialties have signed on. Other communities have gone a different route.
You do the best you can to fix them at the primary care level. If you can't, they end up in the emergency room as their only alternative. What do you do for that specialty care? So we solve the problem, and many of the specialists in the Hillsborough Healthcare Plan participated in this pro bono work because they felt it was their duty to the community. So when the plan came along, most of them said, heck, I'm going to get something where I was getting nothing.
And it's organized.
And what they did is they said, you know what? I am now, instead of able to see 5 patients of yours a year, I can now see 45 patients of yours a year. The plan really is a great model. And the other thing that I think benefits the plan is the recipients through sales tax are participating. Granted, maybe at a lower level, but everybody pays into the plan.
Yeah.
So even the users of the plan. Now, Florida's unique.
And anybody potentially could become a user of the plan.
Anyone potentially.
They're above for the grace of God, or any one of us without
that is very true.
Best known is the system of charitable care developed by the American Project Access Network.
What's happened here in Asheville in Buncombe County has been that we've taken the existing players in the safety net and we've strung them together and created a continuum of care system. We have gone from providing medical care homes to 50% of our uninsured to providing medical care homes and access to the full continuum of care for 97% of our uninsured.
We're looking at taking what we're learning with Project Access and then the Jesse Tree model and trying to do and implementing them together. So actually Ted Hanley, Director of Jesse Tree, and Alan McKenzie, Director of Project Access, are very excited about that possible approach.
And in talking with Ted Hanley, he believes that there's a lot that we can build off of the development work that they already did on the IS system the ability to automate referrals and to track them, which seems very much in line with kind of where we're going with our IS development.
Is there a way that we can start really pulling all these together? And that's where personally it really excited me, because I see all those linkages as part of the 100% Access Project.
So we're able to take something that felt predictable, because these communities have been able to achieve some of the outcomes that we were hoping to achieve, and make them bigger than they were on their own by blending them together in a unified strategy. Where Communities Joined in Action really helped us, it actually builds towards a larger national movement where people get recognition and feel like what they're doing is part of something greater.
The challenge for our project, as for others around the country, would be to integrate best practices and add our own variations to the mix.
The group I was working with never thought they could get a federal grant, a $400,000 grant. I mean, it just seemed unthinkable. And sure enough, we did. And now people are learning that we're part of the national environment, we're part of the state environment, we're very much part of the local, regional environment.
From a faith-based perspective, I'm saying love your neighbor, take care of everybody, nurture them, meet their needs. From a healthcare perspective, they're saying manage that disease, keep them out of the ER. From an economic standpoint, the legislators are saying, quit spending those Medicaid dollars, save that money. My job is to figure out how we get everybody to the table.
In this day and age when there's so little money, everybody wants to put the money into direct services, and by God, most of it needs to be there. But if you eliminate the ability of communities to sit down and do this work, you miss out on some of your best, most cost-effective strategies that allow you to increase capacity in any number of ways, as well as find innovative solutions to community problems.
I try to use what we learned. We've served about 16,000 people in our regional access program. Take those stories, have them add up to something, make sure that these people don't get lost as we think about the future, and then also to use the patterns that we see across those 16,000 people to help us build a better system.
I do believe we'll find the best solutions that fit our communities if we can do this locally, and if we can communicate with each other readily and easily about best practices, about new ways of doing things.
But